Hello.
Hello, Andrew. This is Jacqueline Eckern.
Hi, Jacqueline. I'm going to just switch you over to my headset. I think you'll hear me better in a second.
Thank you.
Jacqueline, can you hear me?
Yes, I can.
Okay, great.
Can you hear me okay?
Yes, I hear you fine.
Okay, great. Andrew, could you pronounce your last name for me? I'm struggling.
It's Kolodony.
Kolodny, so Dr. Kolodny. Thank you. I can do that. Not too difficult. So you're on a long road trip and kindly agreed to answer some of these questions for us with Dr. Gold.
Yes.
That is wonderful. So he had emailed the questions to you, and I've got them here, and I was planning on just recording this, and then after we're done, we'll have that recorded video, but we could also transcribe your answers, so we would have both options available. Is that good with you?
That sounds good. I think we may want to tweak the questions a little bit, but we can sort of go through his list. But yeah, that sounds great.
Alrighty. If you like, I can just kind of MC and pose the question as he wrote it, but then you can massage it in your response however you want.
Well, we might want to just change the question. Let's just start with the, but we can try to work with his question.
You bet. You bet. Okay, so did you want me initially to revise any of these questions for you, Dr. Kolodny?
I'm driving right now, so I can't look at them. And I glanced at them, and I thought some were good, but I thought some we could change and ask different questions. So let's just go down the list and see how we do.
Alrighty, that sounds good. So would you like me to read you the questions and then you tell me if we want to axe any of them or reframe them, and then we do the interview, or just go ahead and start the interview?
Yeah, I will. I mean, if the question's fine, I'll just go ahead with an answer, and if I think we should change it, I'll let you know.
All right, that sounds good, doctor. All right, so the first question, forgive my pronunciation and please correct it if I'm making a mistake. Naloxone or Narcan use is increasing, and some have found repeated overdoses by the same person. What should be done immediately after an overdose reversal with Narcan?
Okay, so I'll go ahead and just answer that question. Oh, gee, I'm really sorry. It's starting to rain very hard. Are you able to hear me okay?
I hear you great. I cannot hear the rain.
Okay. Oh, that's great. Okay, and hopefully it'll let up. We making naloxone more available in the midst of an opioid, or I should say, making naloxone an opioid overdose antidote more available in the midst of an epidemic where opioid overdose has become a leading cause of death in the United States is a no-brainer. Naloxone should be available anywhere somebody could experience an overdose. It should be available. It should be as available as autodefibrillator devices are. We should have naloxone in schools, college dorms, drug treatment programs, even in a Starbucks, because people are overdosing in the bathrooms of Starbucks. And it should be available to people, to the family members of people who have opioid addiction, as well as to household members of people, or to family members of people receiving opioids for chronic pain treatment. We should be doing everything we can to see that it's nearby if someone is experiencing an overdose. The United States has been doing a very good job of improving access to naloxone, and many cities and counties are distributing naloxone for free. There are first responders, policemen carrying naloxone in many municipalities. And in many areas, it's been made available over the counter in special settings. So all of that is great, and we're doing a terrific job of expanding access to naloxone. Yet, overdose deaths are continuing to skyrocket. We're doing a better job than any place else in the world in making naloxone available, yet we have far more opioid overdoses than anywhere else in the world. So, making naloxone much more available and continuing to improve on it, but it's not making much of a dent, because when you rescue somebody with naloxone, if you don't see that they're able to easily access effective addiction treatment after you rescue them, then you just have to hope someone's around with naloxone the next time they overdose. And many overdoses occur in people's sleep, or when they're alone and there's nobody else around who could rescue them with the naloxone. You can't give it to yourself. And so, yes, we've done a good job with naloxone. We have more work to do in making it even more available, but it's not enough. It's necessary, but not sufficient.
Thank you. And if someone has an opioid use disorder and was treated for this, should the friends and family carry and be trained in Narcan reversal?
If someone has opioid use disorder, it should be in their home. The same way someone with allergies would have an EpiPen in their house. We understand that opioid addiction is a chronic disease, and people are prone to slips and relapses. And so, yes, family members should have it even if their loved one is in recovery.
Thank you. Do most treatment facilities encourage that and help supply and prescribe it?
I don't think that very few treatment programs are ensuring that their patients who are opioid addicted have naloxone in their homes. I think that there may be rehabs that have this incorrect notion that people are going to walk out of their program and never use again. And of course, that's not at all what usually happens.
Right.
What usually happens is that people will relapse or slip, and especially if they're not receiving effective outpatient treatment. So you can almost guarantee if they're not receiving treatment that they're going to wind up relapsing pretty soon.
Sure, that makes sense to me. And how would you suggest if someone did have naloxone at home, how they would treat the individual? Do they need to catch them immediately and administer it?
Yes. As soon as you see that someone's experienced an overdose, you want to immediately administer the naloxone and then call 911.
Okay. All right. So the recent overdose of Demi Lovato and others raise an issue about post-addiction treatment abstinence and if moderation of drug use is possible. If someone is an addict, can they use other drugs moderately and not risk a relapse?
I really don't think there is such a thing as an addict. I don't like the term, not just because it's stigmatizing to define somebody by their condition, like calling somebody with schizophrenia schizophrenic. I wouldn't do that either. But with addict, the term addict, not only is it a stigmatizing term, it's incorrect. The term addict, I think, implies a certain type of person, implies an individual who's using drugs because they want to get high from them and may not care about who they hurt along the way. And there's even over the years been this notion that so-called addicts have antisocial personalities, and none of that is true. There are certainly many people suffering from addiction, and there are many people who became opioid addicted, taking opioids because they liked the effect, and that's how they got addicted. There are also many people who become opioid addicted, taking opioids exactly as prescribed by doctors. Once somebody becomes opioid addicted, what drives their continued use more than anything else isn't a desire to get high. It's not the seeking pleasure that drives them to continue to use, which I think the term addict implies. What drives continued use once somebody has become opioid addicted are the negative symptoms, the dysphoria they experience when they stop taking the drug. And so we really don't have addicts. We have people suffering from the disease of addiction. And with regard to moderation, I think when we talk about moderation, there are people. It really depends on the drug that you're talking about and the individual. So, for a drug like alcohol, most of the population is able to consume alcohol repeatedly without becoming addicted to it. About 10% of the population gets into real trouble with alcohol, develops alcohol addiction, And when we look at that 10% that becomes addicted to alcohol, although we haven't identified the specific gene or genes, we do know that alcohol problems run in families, and we have a good understanding that genetics play an important role because most of the population doesn't develop alcohol addiction. For the 90% of us that don't become addicted to alcohol after using it, moderation is extraordinarily important. Risky drinking in a harmful way, is a very common problem, and there are many health and social problems that can stem from risky drinking. And so, moderating one's alcohol use is really something we should all people who consume alcohol should try to moderate their use. Opioids are different. Opioids are more like nicotine. Opioids are highly addictive drugs. Almost anyone who repeatedly exposes themselves to a highly addictive drug is going to be very high risk for becoming addicted. It's not like alcohol, where 90% of us, with highly addictive drugs, repeated use can cause addiction in almost anyone. The people who can use a highly addictive drug repeatedly and not get addicted are the exception rather than the rule. And when I talk about highly addictive drugs, I'm talking about nicotine, heroin, oxycodone, hydrocodone. These are highly addictive drugs, and I don't believe that repeated use, even if or using moderately, is a safe thing. Trying to use moderately is a safe thing to do. If you try to moderately use heroin or oxycodone,
Dr. Kolodony, are you still with me?
yes, I'm still here.
Great. It just faded out just temporarily. It must have been just something
So
temporary.
the last thing I said was that if you try to use heroin or oxycodone or hydrocodone or nicotine moderately, you're playing with fire. It's
Yes.
very easy to become addicted. It's very easy to become addicted to those drugs. And once somebody becomes addicted, it becomes next to impossible to use moderately.
Interesting. So in the case of patients that have opioid use disorder, can you describe how methadone helps patients and what the drawbacks of methadone use are for these individuals?
Sure. The first line treatment for opioid addiction, the treatment that is most likely to help most people with opioid addiction, is opioid agonist treatment. And by opioid agonist treatment, I'm referring to buprenorphine and methadone. These are the treatments that strong evidence tells us can treat are effective treatments. Opioid agonist therapy decreases an individual's likelihood of experiencing an overdose and increases the likelihood that they will be functional and have a good quality of life. And that's true for buprenorphine and methadone. Methadone, I would say, methadone, I believe, is second line to buprenorphine. Buprenorphine should be considered first because it can be prescribed from a doctor's office and filled at a pharmacy so that a patient doesn't have to visit a clinic every day to obtain it. They're able to treat their opioid addiction in a setting with privacy and dignity rather than having that individual line up at a methadone clinic. And the reason we can treat opioid addiction with buprenorphine that's prescribed by doctors and dispensed at pharmacies, unlike methadone, which has to be administered under supervision to people in special clinics. The reason we can do this with buprenorphine is because it's much safer than methadone. Buprenorphine is a unique opioid. The term we would use to describe it is partial agonist. It's a partial agonist opioid. And that makes it much more difficult for people to overdose from it. There's a ceiling on its effects, even if a patient takes a large dose. That's not true for methadone. Methadone is an especially dangerous opioid, and when it comes to overdoses, if prescribed by doctors. And so for methadone, it does, unless a patient is very stable, it should be administered from a methadone clinic under supervision. There's one other advantage to buprenorphine over methadone, which is that the drug is less sedating. Patients will feel more alert on I'm sorry, I hope I didn't get that wrong. I meant to say another advantage of buprenorphine over methadone, and that's that patients on buprenorphine will feel more alert. Some patients on methadone will complain of feeling tired from it and sort of falling asleep too easily. And so buprenorphine is safer. It causes less sedation and can be prescribed in primary care settings so that people can have their opioid addiction treated the same way their other medical problems would be treated. Those are the advantages of buprenorphine. All of that said, there are some patients who do need methadone and for whom methadone is a better option. For example, a patient that hasn't done well on buprenorphine, or a patient who may have a chaotic lifestyle and may benefit from the structure of the daily visit to the clinic. Those would be examples of patients for whom methadone may be the better choice. It's very good that we have methadone maintenance right now because access to buprenorphine, even though it's the first line treatment, is inadequate. And if we didn't have methadone maintenance programs, I believe that the national overdose death rate would be much higher than it currently is.
Very sobering. Can you describe how Suboxone, or I think it's pronounced buprenorphine, helps patients?
That's what I've been saying, yes, buprenorphine.
Okay, okay. Those are just another form of, there's methadone or there's the Suboxone or the buprenorphine.
Buprenorphine and Suboxone are the same thing.
Got it. Thank you. Thank you. And then can you describe how naltrexone and Vivitrol help patients and what the drawbacks might be?
Vivitrol, or now extended-release naltrexone, has much less evidence to support its use. The clinical experience with treating opioid addiction with naltrexone shows very high dropout rates. Most patients don't stay on it very long. Many patients will quit taking the drug after 1 or 2 injections. It's a monthly injection. It's a painful monthly injection. And the drug works by blocking your opiate receptors, which means that you're not only are you blocking exogenous opioids from having an effect. By exogenous opioid, I'm talking about opioids you would take, like methadone or heroin. It also blocks endogenous opioids. So some patients feel well on it, which is also may explain why we see such high outrage.
Mm-hmm.
There's also evidence that treating people with naltrexone may actually increase the risk of an overdose death, because after they've had their opiate receptors blocked, naltrexone, their injection extremely sensitive to opioids. And so even a moderate dose can potentially cause a death. We do not have good evidence to tell us which is the medicine for which type of patient. We don't have good evidence to tell us this kind of patient should get buprenorphine, this kind of patient should get methadone, and that kind of patient should get Vivitrol. We don't really know. But I believe that patients who have moderate to severe opioid use disorder should be receiving either buprenorphine or methadone. I think for some patients with mild opioid use disorder who have not been addicted for very long, that Vivitrol is an option to consider. But I'm very concerned that Vivitrol is being aggressively promoted and used in people with severe opioid addiction who would be better off on buprenorphine or methadone. I'm talking mainly about the criminal justice system and drug courts. There is a bias against treating opioid addiction with buprenorphine and methadone, especially in justice. Something that the manufacturer of Vivitrol has taken advantage of to play up on fears about buprenorphine and methadone in marketing their product. And I'm very concerned that we're seeing an aggressive push to use Vivitrol in patients who I think will do very poorly on that drug.
Very concerning. In addition to the questions I've asked you, what program or treatment ingredients make a 5-year positive outcome more likely for someone struggling with substance use disorder overall?
I think the outcome may have less to do with, good outcomes may have less to do with what the patient is offered and more to do with the patient's individual characteristics. A patient who develops opioid addiction later in life after having had stable employment and having established significant relationships. An individual who then becomes addicted, for example, a middle-aged person who becomes addicted to pain medication prescribed to them by a doctor, that individual may do very well with just a buprenorphine prescription and not require much additional psychosocial support. An individual who develops opioid addiction earlier in life and transitions from prescription opioids to heroin, and then transitions from snorting heroin to injecting heroin, and it happens earlier in life before they've really matured, that individual is more likely to have that individual is going to be harder to treat and may experience more relapses and slips. That individual is also more likely to require psychosocial support and counseling in combination with a medication like buprenorphine or methadone.
So in addition to medically assisted therapies, some of the treatments that you're recommending sound like more supportive therapeutic options. And do things like cognitive behavior therapy or dialectic behavior therapy help?
Yes, they do. I think more for addiction, probably more CBT than DBT. But yes, CBT is a very important component, especially if the patient is interested in coming off of buprenorphine or methadone. There are many people who can do well while taking those medications, but when they try and come off, if they're not receiving cognitive behavioral therapy, if they're not learning how to identify triggers and respond appropriately, if they're not learning how to respond to cravings, they will be very high risk for a relapse. So it's critically important when patients are trying to come off of medication-assisted treatment.
Absolutely, that makes sense to me. Well, I very much appreciate your time and insight on all of this, Dr. Kolodony.
Well, you're very welcome. And when you're done writing this up, I'm happy to take a quick glance at the draft and maybe tweak it a little bit.
That is very kind of you, because there was just a few places where the car was out of range a little bit, and I want to make sure I get it as accurate as possible. So I will definitely send you the transcript to take a look at and let you look over all of it just to know what we're putting out there. Okay, sir?
Sounds good. Thank you.
Thank you, doctor. Have a safe trip.
All righty. Take care.
You too. Bye-bye.
Bye.